Hello and welcome everybody. Thank you so much for joining us this evening for what we all hope will be a very interesting and informative evening. And just to let you know, this talk is being recorded, so we'll be able to distribute the slides and the presentation at a later time later on. My name's Emily and I'm a GP in Cardiff. I'm also a patient with inflammatory bowel disease. Was diagnosed when I was 19. And looked after very well by Dr. Barney Hawthorne, who's one of our speakers today. So hopefully this talk will help you understand a bit more about the condition, why it's happening and what the treatment options are available to us. And you know, I know exactly what you're all experiencing, so it's nice to be part of this talk today. You're welcome to send in questions through the chat as the talk's going on, and we'll either answer these as we're going along or at the end of the presentation when we'll have about 30 minutes for question and answer session. We're keen for you to ask as many questions as you need to. They're all going to be anonymous, so please don't ask any personalised questions, but we would be able to generalise them because they'll be relevant to lots of the members of the audience today. If you make a note of the slide that your question relates to, if you want to, you'll see that there's a slide number at the bottom left-hand side of each slide, and then that will help us flip back to the slide if we need to, but it's not important if you don't need to. We have a few thank yous to get through first before we introduce our speakers for the evening. So a big thank you to the Wales Health Collaborative and the Value-Based Medicine team, and also a big thank you to the charity Crohn's and Colitis UK, which I'm sure you'll all have heard of and be familiar with already. And so thank you to them for making this evening possible. We've got three wonderful speakers for you this afternoon, all with different areas of expertise. So now I'd like to hand over to Barney Hawthorne, who introduced himself and the other speakers.
Okay, thank you very much indeed, Emily. That's great. I'm a gastroenterology consultant. I've worked in Cardiff for many years, and I did my training and research in gastroenterology with a special interest in IBD. And I've run the clinic in Cardiff for many years until I went part-time a couple of years ago. So I'd like to ask Ceris ap Gwilym to introduce herself, and then Helen.
Oh, hi, good evening. I'm Ceris ap Gwilym. I'm a GP up in North Wales in Bethesda, but prior to becoming a GP, worked as a gastroenterology registrar and trained with Barney, and since becoming a GP, I've developed a specialist interest in IBD following on from my gastroenterology days, and I run a weekly clinic in inflammatory bowel disease in Ysbyty Gwynedd, and I've also done some work with the Royal College and Crohn's and Colitis UK. I'll hand over now to Helen to introduce herself.
Hello everyone, thank you for your time this evening. I'm Helen Ludlow. I'm the lead inflammatory bowel disease in Cardiff, so that covers University Hospital of Wales and University Hospital Landoc. I've been in this role for about 18 years, and part of that I'm also an endoscopist as well.
Okay, that's wonderful. So why don't we move on and start the talk then? So if we could have the next slide. Okay, so I'm going to start with this one. What is IBD? IBD stands for inflammatory bowel disease. Don't confuse this with irritable bowel syndrome. The difference being that IBD involves inflammation of the bowel. If you look in the middle picture here, that's a schema of your insides. And if we look to the left, we can see a little bit of information about ulcerative colitis, which I will call UC because it's quicker. And UC is an inflammation of the colon or the large bowel. Next slide. Sometimes it involves all of the bowel. It always extends from the rectum. And in this picture, it shows it extending right the way around to the cecum. That's where your appendix is. Next. In some patients, it just extends up the lower part of the bowel. That's called left-sided colitis because doctors label everything back to front, which is very confusing for patients. But that is the left side of your abdomen, trust me. And next. And sometimes UC only affects the rectum. Rather confusingly, we call that proctitis, but it's still UC, okay? And then if we look to the right-hand side of the diagram, we can talk about Crohn's disease. Crohn's disease is a bit more complicated. Next. Sometimes it affects the colon, like UC does. Next. Sometimes it just affects the bottom of the small intestine. That's called the terminal ileum. Not terminal because you're dying, terminal because it's the bottom end of the small bowel. Next. Sometimes it affects both. And the inflammation is often patchy. In other words, there can be a segment of inflammation, then a normal bit, then another segment of inflammation. And you don't get that with UC, which is continuous around the colon. Next. Sometimes it involves the perianal area around your bottom, where it can cause abscesses or little fistulas. That's a hole through the skin where a bit of mucky stuff comes out. Next. Sometimes it affects the upper part of the small bowel. Next. And it can also affect the duodenum. That's the bit just below your stomach. Next. The stomach itself. Next. Rarely, it can affect your esophagus, your gullet. Next. And it can affect the mouth, and it can cause swelling and ulcers, and it can even cause swelling of the lips, which is more common in children and young people. Okay, next. So, who gets IBD? This is really interesting. We think that IBD only started to appear as a disease in the mid-1800s. And it's quite interesting that it appeared first in industrialized nations. And as you can see from this graph, the green thing, which is the increase in cases of UC, that started first. And then later on, Crohn's started to develop and became more common in the 1900s. And then what's even more interesting is that other countries like India and Pakistan, Africa and the developing world, who were not industrialized, didn't see it at all. But now that they are becoming urbanized and industrialized and living in cities, etc., they're starting to get it. And the pattern is exactly the same. First of all, they see UC and then they see Crohn's. That rise in cases is very quick. It's too quick for our genes to change, and it points strongly to there being a factor in the environment. Next slide. And the question is, what is that factor? And if we look at on the left-hand side here, there are genes that make you more likely to get IBD. There are more genes affecting Crohn's than UC. So if you've got Crohn's in the family, it runs a little bit more strongly, but it's not just genes. As we've shown, the rapid increase points to environmental factors. And we think that that also affects the immunity, the way that your white cells respond. And in a way, IBD is an inappropriate inflammation in the wall of the bowel, driven partly by the bugs in your gut. Now, we're going to come back to talking about bugs because clearly the bugs in your gut are very much influenced by your diet. And then if we look on the right, just very briefly, there are lots of factors that make it more likely or less likely if you develop Crohn's. And the red arrows are where there's an increased risk, and the green down arrows are where it reduces your risk. And so the first line there, smoking, is really fascinating. If you're a smoker, you're more likely to get Crohn's and you're less likely to get colitis. And it's completely opposite, and we don't know why. And my predecessor in Cardiff, John Rhodes, discovered that association. And then we haven't got time to go through all this, but just a brief thing. Crohn's disease particularly seems to be more common if you have a very clean childhood. And so if you have you're not exposed to bugs when you're little, you're more likely to develop Crohn's. The same does not apply for UC. And if you have multiple courses of antibiotics in childhood, you're slightly more likely to get Crohn's. We haven't got time to go through the rest of that, but we'll come back to it. Next.
Thank you. So over to me now. So if you or someone you know has been diagnosed with inflammatory bowel disease, these words remission and flare-up are things that you're going to hear quite often throughout your treatment another time. So remission generally is when your treatment is working and you feel well, and flare-up generally is when you have symptoms and the treatment may not be working so well. Now, we've actually had a couple of questions in advance about remission and flare-up. When will I know? And I think it's important to say that remission can actually mean different things to different people. So remission to patients in particular is if they're in symptomatic remission. So that means they're not getting symptoms. Terms that you may also come across, and particularly if you're involved in any clinical trials or you may hear during your clinic appointment, are the phrases endoscopic remission and histological remission. Endoscopic remission is when you have a colonoscopy and it looks okay. So with the eyes on the screen, it looks okay. We might say, well, you know, macroscopically or to the naked eye, this looks calm and quiet. But then sometimes the biopsies may show that there is still some inflammation there. And so one of the questions was actually, can you be in a flare-up without having blood or diarrhea? And yes, I mean, that is entirely possible. And bear in mind, you know, I tell people to think of their bowel sometimes as a bit like a wound. You know, if you have a wound on your arm, just because it's not bleeding, it doesn't mean the wound is fully healed. So, you know, everything can be on a line of completely in remission, completely under control, to actually really quite severe. And you may fit somewhere along that line, and that may change regularly. So how do we know as well? I mean, we have certain tools available to us. Obviously, endoscopy is probably the gold standard for us actually looking and taking biopsies, but I'm sure you wouldn't appreciate having regular endoscopies. So tools, Fecalcal protectin, it's been around now probably about 5 years, incredibly helpful investigation where a small stool sample can give us information about levels of inflammation within your gut. A one-off reading isn't particularly helpful, but repeated readings give us a graph or a trend of whether the inflammation is staying the same, whether it's getting worse or getting better. And that's a really helpful tool that we can use to sometimes see what's going on with you. If you've got symptoms that we're not quite sure, is this a flare-up or is this something else? And certainly for when we're trying to decide whether you're responding to treatment. The other investigation that isn't as helpful as you might think is blood tests. You may have heard of results, a CRP, which is a protein measurement, or ESR, which again is a cell measurement. They can be helpful in certain circumstances, but if a patient says to me, oh, I'm waiting for my blood tests to tell me if I'm having a flare-up, actually most of the time that's not particularly helpful, because as you can imagine, blood circulates throughout your body, and if you've got a raised level, it could actually be inflammation or infection in your ear or your toe, whereas the stool sample is very gut specific. So blood samples, it plays a role, but it's not the be all or an end all. And Fecalcal protectin, again, it's very, very useful, but just part of the jigsaw. And there on the side there, we've mentioned some of the symptoms that you may or not be experiencing. Not everyone has them all. Not everyone has them the same ones each time. So just things that you may come to expect. And next slide, please. So why am I experiencing a flare-up? I mean, I've put up the bottom there. Sometimes we just don't know. on frequent occasions, we can certainly get a bit of a hint what might be going on, and we're often very keen to exclude infection. So if someone is presenting with diarrhea, you know, it's not always a flare-up. It could just be that you're having a bit of diarrhea for a while, the same way someone without inflammatory bowel disease gets, you know, perhaps something you've eaten. It could certainly be a change in any other medication. Certainly medication to be aware of are drugs they're called non-steroidal anti-inflammatories. So we know that drugs like ibuprofen, diclofenac, certain antibiotics can actually make symptoms worse, that can give you diarrhea, can actually just make your symptoms worse, or they can make the inflammation worse there as well. And not taking medication. So, you know, it's important, unless there is good reason, please do take your medication as prescribed, because there's been significant drug trials done on this medication, and it's taking it as and when you're supposed to. So gaps in treatment can certainly set things off. Increased stress or other illness absolutely can drive it can drive inflammation. It can also drive bowel irritability, all of which can lead you to having symptoms of a flare-up. Sometimes medication does stop working. In particular, we see this in what we call biologic medication, and some of these treatments we can actually test whether your body is developing antibodies to the drug, in which case as soon as we give you the drug, your body is actually destroying it. And so we can check certain drug levels as well, not for many medication, but certainly some of them. And also you can become intolerant to your medication. Certainly drugs like azathioprine, mercaptopurine, certainly drugs like steroids, you can have significant problems with, and you know, that you can't take anymore. And then, as I said at the bottom, sometimes we just don't know why you're having a flare-up, but the important thing is to recognise it and to have a plan with how you're going to plan to deal with that. So next slide, please.
Thanks, Helen. So we're just going to move on to talk about some of the medical therapy options that Helen's already mentioned. So many of you listening tonight are going to be very familiar with a drug called Masalazine, particularly those of you that suffer from ulcerative colitis. You may know it better as Octasa, Pentasa, or Azocol, and so forth. So this medication works to reduce the inflammation in the lining of the bowel, and this allows the damaged tissue to heal. We can use this to both induce and maintain remission, words that you've heard Helen mention. And what we mean more simply is it can settle the inflammation down when you've had a diagnosis in the first instance, and then we use it in the longer term to prevent that inflammation from flaring up and to try and keep your disease quiet. It plays a huge role in the management of ulcerative colitis, but it's less evidence-based in the sort of widespread use for Crohn's disease. Helen's mentioned already the importance of continuing this medication long term, because what we know is that keeping that inflammation quiet is actually going to reduce your risk of complications such as developing colorectal cancer years down the line after having disease that might be just quietly unsettled in the background without these medications. Masalazine comes in many different forms, and you can see from the slide it comes as what we call rectal preparations, so preparations that go up the bottom. These are suppositories, and then enemas that can be liquids and foams. Barney's already mentioned different areas of the bowel that can be affected, so depending on where your disease affects, different medications may be more appropriate. And it also comes in tablet and granule forms that are taken by mouth. And it's very common that we prescribe these both individually and in combination. And how you use them might depend on the extent of your disease, how active it is, and whether or not you're flaring and so forth. Next slide. Again, I'm sure as we step up the treatment ladder, many of you will have been on steroids at some point. So these are very useful medications for bringing active disease under control. For example, in ulcerative colitis, where the Masalazine hasn't worked, or often as a first line in Crohn's disease. They can also be used to manage flares that Helen's mentioned, you know, how we detect those already. However, they do carry a lot of long-term side effects, so we really they don't have much of a role in the long-term management of either condition. The ones that you're most likely to come across are prednisolone and budesonide, and again, like the Masalazine, these can come in both rectal and oral forms. However, the frequent or the long-term use of steroids and the difficulty in coming off them is a really good indication that we need to be stepping up your treatment. So we step up this treatment pyramid that you can see here, and the next class of drugs that we move to is the immunosuppressive medications. The most common of these is azathioprine. Mercaptopurine and methotrexate are out there too, but azathioprine is probably the one we most commonly use in IBD, and again, I'm sure lots of you will be familiar with it. About 6 in 10 IBD patients will need this at some point during their management of their disease. And these medications work to dampen down the immune system, and this settles the inflammation. But because of its overall dampening down effect, it does slightly increase your risk of getting infections. These will also need regular blood monitoring, and to start with, that will be weekly, but once you're stable, that will reduce to 3 monthly. Next slide. And then as we come to the top of that treatment pyramid, you've already heard mentioned biologics and biosimilar medications. So if your disease continues to be active and we're not controlling it adequately, despite the medications we've mentioned so far, we'd usually move on to starting a biologic or a biosimilar agent. Tend to be used more often in patients with more moderate or severe disease, and they work by blocking different parts of the immune system that have become overactive in inflammatory bowel disease. And they, as you can see from this diagram, they work in different ways and they block different parts of the immune system. So as Helen mentioned, you may become intolerant of one, or either you can't tolerate it or your body becomes too used to it. But that doesn't mean that you won't be able to try an alternative and have a good result from that. And these come with very long names, so I'm not going to list them at all. But they also come in lots of different ways that they can be administered. So you can have them through an injection in the vein, which will be given in hospital as an infusion. You can be self-taught to give the injection just under your skin, and more recently there are tablet versions out, which is at present licensed for ulcerative colitis. Not all medications will be suitable for everybody, and obviously it needs to be individualized. And I've talked mainly now about stepping up treatment. There may be patients out there that have actually gone on a step down treatment where they've presented with a more severe episode, where some of these more aggressive medications need to be used early on in the disease, and treatment can be stepped down as we go along as everything settles. Next slide.
Okay, so I'm going to say a word now about surgery, but before I do, just to emphasize, many patients have mild UC and mild Crohn's, and because we're trying to cover everything, a little bit of everything in this talk, please remember that you're not going to experience all of this, and not that many of you will have surgery, but it's just important to know that it is a treatment option. For ulcerative colitis, the standard treatment, if medical treatment flares, or if you are incredibly ill with severe acute colitis comes on suddenly, you might have to have a colectomy where the colon is removed and the small intestine comes out through the skin as a stoma. So you'd have to wear a bag. Okay, that's called a colectomy or a subtotal colectomy. Now, of course, many people don't like to have a long-term stoma or bag, and so there is an option to have a reversal where that small intestinal ending is brought down to the anus, turned back on itself into a J shape, and forms a pouch. It's often called a pouch operation, which means that you can go to the toilet again and you don't have a stoma, but I would stress it's not normal. We weren't designed this way, and so it's not like going back to being completely normal, but for many people it's worth it if they're desperate to avoid a pouch. We don't do pouch operations if you've got Crohn's. Next slide. As I've said already, Crohn's is more complicated because it can affect different parts of the gut, and this is just 2 standard operations that are sometimes done, again, for people who are very unwell suddenly, or for people where medical treatment has not worked. And so on the left here, we have an ileocecal resection where that last bit of ileum is removed, and they always take a bit of the cecum, a bit of the large intestine with it, and they join the 2 ends together, no stoma. If, however, it's the colon, the large bowel, that's the problem, that requires a colectomy, and usually that means that there will have to be a stoma bag called an ileostomy. Okay, next slide.
Okay, so I'm sure that you'll all be very familiar with the need for IBD patients to undergo frequent blood tests. We've mentioned already that they might be used to pick up a flare. Many of you will have had many done in the initial diagnosis. And sometimes we just use them to keep an eye and make sure that the disease is quiet. They're an integral part really of management. Some of the medications I've mentioned already need regular blood test monitoring, and we can also use them to pick up things like vitamin deficiencies, so things like lack of B12 and iron that can come hand in hand sometimes with your condition. Again, I doubt that anybody here has managed to get this far without having to provide many a sample of poo. And as Helen's mentioned already, we do these for a couple of different reasons. So they can be used perhaps in the instance of a flare to exclude an infection as a cause for the flare or an infection as a cause of the symptoms. And more commonly these days, we're requesting Fecalcal protectin tests. Helen's mentioned these briefly already, but it can be very useful at the time of diagnosis, or in GP land, they can be very useful for us excluding or making IBD less likely in patients presenting with symptoms that overlap. But increasingly, they can be very useful for us monitoring how well controlled your disease is and seeing what pattern they're following. And again, that comes back to seeing whether your disease is quiet, not just how you're feeling, but how the actual inflammation is behaving. Again, I suspect that endoscopy is a test that you're all familiar with. A thin, flexible camera. It's used to look inside the intestines, and we use these in a couple of different ways. A flexible sigmoidoscopy, great for looking at the bottom end of the lower of the bowel. Doesn't need the same kind of preparation, can be very useful when people are poorly, needing a quick look, perhaps in the initial stages, getting a biopsy, but it doesn't give us an examination of the whole bowel. For this, we need colonoscopy, and this looks at the whole bowel and sometimes even goes into the terminal ileum, as Barney mentioned earlier on, for us to see if there's inflammation there as well. Difficulty with colonoscopy is it does require full bowel prep, which is a lot of drinking a strong laxative. And sometimes patients report that they find this the most difficult part of the test, really tolerating the prep. Again, there are different ways that you can be prepped for it, and hopefully your individual care providers will talk to you about that. Occasionally, as Barney mentioned, it can affect the upper GI tract, the stomach and the esophagus, and we need a gastroscopy, a camera that looks through the mouth to look at that. And we sometimes do a capsule endoscopy, which is where you swallow a small capsule that's got a camera in it that can take images of your small bowel. Next slide. Some patients may need to go on to have radiological investigations, so tests that are done in the X-ray or the radiology department. Plain abdominal X-rays tend to only be used if somebody's very unwell, perhaps to look for a sign of obstruction or a very severe flare and the bowel being dilated. And we used to use barium studies that looked at how liquid flowed through your gut, but thankfully these have been superseded really by the quality of MRI scans. So MRI enterography, fantastic for looking at your small bowel, give us wonderful images, can pick up flares, can pick up inflammation, can pick up narrowings. The difficulty being some patients find it claustrophobic. So an alternative is a CT scan, and you can use a CT enterogram to look at the small bowel, which is a quicker test. It's less claustrophobic, but it does involve radiation. So we would probably just be cautious about how often we were putting particularly young patients through these. Next slide.
Thank you. So back to me. So the very fact that you're here on this meeting means either that you have inflammatory bowel disease or someone that close to you has and want to know a little bit about it. Now, living with inflammatory bowel disease, what should I expect? Gosh, I mean, there are some huge topics here: diet, work, education, energy, mental health, relationships. So please bear in mind, I've only got a few minutes really to cover them. So please don't think that if any of them, if you don't think I give them the full detail that they deserve, but there are certain aspects I particularly want to talk about. Now, diet, this is something we are asked about all the time, and obviously, you would expect that whatever goes in your mouth affects the rest of your gut as it travels down through, and certainly to some extent that is true. I think if we were having this presentation in another year or even another 2 years' time, probably I would be able to tell you a lot more, because fortunately, and thank goodness, there is suddenly a lot more research and interest going on into this area. Now, there is a really good information leaflet booklet available from Crohn's and Colitis called Food, Your Guide. And if you've not seen that, I would certainly recommend have a look at it online, and it's free. You don't have to be a member to access that. Really what that is saying, though, with the evidence that trials have told us so far, is that there isn't a specific diet that we would recommend, or that you should eat or that you shouldn't eat in most cases. There is growing evidence that a Mediterranean diet may help. Part of this is because there is growing evidence that the bugs that live in our bowel are certainly related to an inflammatory process, and there is some evidence that the Mediterranean diet helps keep those bugs as happy as possible. However, as with everything, there's a caveat to that. There are certain people that have got the best diet in the world and still have active inflammatory bowel disease. So, this is something to consider and have a look at, but please do not beat yourself up over that either, you don't eat good enough, or you don't provide good enough food for your family, your children, your loved ones. This is a growing area of research that's currently being undertaken. That said, a couple of specific things. Fibre, you certainly can have too much fibre, and you can certainly have too little fibre as well. So it's finding out what is more comfortable for you. There's soluble fibre, insoluble fibre. What you want to avoid is constipation. But some people do struggle with fruit and veg, and that can be an issue as well. Food sensitivities, intolerance, there is a big difference between being allergic to something or being intolerant to something. People ask about celiac disease, and I mean, certainly, it is worth, and you probably have already been checked for true celiac disease, and possibly without you realising, but worth asking your IB team about that. Alcohol is an interesting one. Certainly perhaps beers and things like that can set people off. But then so can red wine. So please just have a think about your diet. It's worth considering a food diary to see, if I'm having a flare-up, actually has something set that off. There's been a question that's come up about probiotics and prebiotics. And again, these are things that may help to keep the bugs in your bowel as happy as possible. We all have bugs in your bowel. They should be there, but it's keeping a fine balance between good and bad. And as I say, this is a growing area. One question that I just want to address that has come up, someone has asked about Chinese herbs. I mean, I would have to just say, please be very, very cautious. The medication that we would give you and that is being discussed has undergone very robust clinical trials for safety to try and minimise the risk. I am just very aware. I had a young lady went to see a alternative therapist. I won't go into too much detail there, but actually had liver failure from it. So please be aware, most medications, certainly potent drugs, things like digoxin that helps regulate the heartbeat, that's all natural. It comes from plants. A lot of our drugs come from plants. So I say to people, just because it's natural or herbal, absolutely does not mean it's safe. So please just be very, very careful. I need to speed up a little bit. Work education, such important. Please do look at the Crohn's and Colitis UK website. They've got information on each aspects of these. Some advice whether you want to talk to your employer or whether you don't. There's some great information there for schools and students. You do have some protection, although this isn't classed fully as a disability. Some aspects of inflammatory bowel disease can do, so you may well have the law on your side as well. So do have a look about that. And basically, if you're having issues with your employer, the question is, are you able to do your job or your studies with reasonable adjustments? And reasonable adjustments, that can mean different things. So, but on the whole, yes, absolutely, you should be able to. So energy or fatigue, this is a huge problem for people with an inflammatory or a chronic condition, and it's something we hear a lot of. And again, this is another area where there is little evidence about it. Now, it's very important to exclude physical causes such as anemia, vitamin B12 deficiency, thyroid disease, diabetes. Okay, so those are generally reasonably simple blood tests that either your GP or your specialist team can do. And you know, if there is a deficiency, then to replace. Please have a think about your mood. And we know that depression, low mood, can be a real significant cause of fatigue as well. It's important to rest when you need to, but also to exercise. I don't mean join the gym and start running marathons, but even gentle walking, particularly outside rather than just on a treadmill, have been shown to reduce fatigue. And be kind to yourself. You know, when you're struggling, do what you would say to a friend, to look after themselves and to take some time out. And again, this will be an area, I'm sure, whether I hope, you know, that there will be further studies coming out where we can actually support you there a little bit more. Likewise, mental health. This is a significant thing. You know, chronic disease, chronic inflammation can have a massive impact on your mental health. And of course, mental health, again, even if you've not got active disease, can be a big problem. Please seek help from someone, and that level of help can differ from talking to a friend, can be having a look online about what information there may be there. Please do speak with your GP if you're really, really struggling. Now, we know the IBD standards say that every IBD service should have access to a psychologist. Unfortunately, very, very few services in the UK have this, and it's something we're all acutely aware of. Your specialist nurses, you know, they can certainly help you to some extent, but again, our scope of being able to help you there is really limited. But please, this is an important one to address, even to recognise, and sometimes even just saying to someone, I'm really struggling at the moment, just to get it out there can actually be the first step in getting that conversation going. Briefly then, relationships. You know, I do have some patients who actually haven't told anybody that they've got inflammatory bowel disease, and that can be a really lonely place to be. And actually, once you start talking to people, you will be surprised about how many people will also say to you, I've got that, or my partner's got that. I know someone like that in work, and it can be really helpful. Briefly there, fertility. The main thing with fertility is if you're wanting to have a baby, make sure that you are as well as possible. Most of our medication will not preclude you from having babies, but if you are thinking of having a baby, either as the woman or the male, please discuss that with your GP or your team, just so we can check that the medication you're on isn't contraindicated. There are one or two drugs that we would say absolutely not, you know, we need to change our treatment, or one or two drugs that are still slightly new and we just don't have that information about at the moment. So next slide, please.
Thanks, Helen. So, you know, sometimes you might find yourself wondering who's the best person to talk to, perhaps about many of the issues that Helen's just mentioned. You know, in an ideal world, you know, we do work closely between primary and secondary care. I hope me being here as a GP presenting today with an IBD consultant and nurse shows that we do try and bridge these gaps between primary and secondary care. But we do know in reality that actually accessing services, it can be tricky. I would say overall, your GP is a great support for generally living with a chronic disease. So the problems that Helen has just talked about, these are problems that we see with a lot of chronic diseases, and primary care is set up for dealing with many of these things. So do please seek their support if you're struggling with any of those areas. In addition to this, things like regular medication on your repeat prescription, your blood monitoring, support with work, time off work, adjustments, support with your mental health, again, you know, and just your general well-being, I would encourage you to involve your GP. When it comes to a flare, I think it's slightly more difficult. Who's the best person to contact? You know, it's completely reasonable to go to either your GP or your IBD team. Some GPs will be more experienced in dealing with IBD, and obviously it's difficult for me because it's my specialist area, so I'm quite confident in it, and I do appreciate that's not the case for all GPs. There is an awful lot of work being done with educating GPs in IBD flare management, so I do encourage you to involve them in it. They will often access secondary care to get advice if needed, or if you've got a clear flare management plan in your notes, they can follow that. It is absolutely essential that you've got an IBD nurse and you're aware who they are. And again, I appreciate, you know, access isn't always as easy as we'd like it to be. For patients perhaps with more complex, more severe, more difficult Crohn's, for example, it may well be that your IBD team is much better placed to help you than your GP, as the management options are not nearly as straightforward. When it comes to getting results of investigations, bear in mind if the hospital have requested it, it may not be available for the GP to access, so probably better to try and seek this information from your IBD team. Next slide.
Fantastic, thank you, Keris. So just very briefly now, how do we talk to people about what's happening? So just to start off, really, you know, bowels is a very sensitive topic, and you may well feel really uncomfortable about talking about this. With regards to your GP and your IBD team, particularly, as I say, I'm a specialist nurse, I literally talk about poo and bowels all day, every day, sometimes even on the weekend, my poor husband. But, you know, say it as it is, we've heard it all. But something that may help you. Now, you'll see there's a QR code on there. If you've got a smartphone, you can hold hold your phone up to that to sort of almost go as though to take a picture of it. And it'll take you to a really fantastic resource on the Crohn's and Colitis UK website called the Talking Toolkit. And I actually had a go at this, and I'll tell you about this. I've created my own little scenario there. So if you need to talk to someone, and that literally can be anyone, it can be your GP, your team, your partner, your children, your friends, your employers, your school, university, it can give you some really good ways of getting going. You know, often that first sentence is the most difficult thing to say, and it covers particular areas such as stomas, fatigue, mental health, what it's like to have an invisible illness, so no one can actually see what's going on in your bowels. You may actually look really, really well. Family issues and work issues. So what will happen if you go to that link, it's going to ask you 5 general questions just to get you going. So it wants to know what type of condition you've got. Have you got Crohn's disease? Have you got ulcerative colitis, microscopic colitis, or are we not completely sure at the moment? How it mainly affects you, and it sort of asks the top 3, you know, like what is your problem? Is it diarrhea, pain, fatigue, things like that? Who do you want to talk to? And I mentioned those people, you know, that you may want to just have some tips about what to do. What is stopping you from talking? You know, is it things like embarrassment? Is it you don't know the terms to use? You don't know your rights and things like that? And what is it particularly that you want them to know? And I think for employers that can be really helpful. And basically it will come up with a bit of a bullet point plan of some sentences, some things that you can get going with. You could, you know, if you're that, I feel that uncomfortable about it, you could just print it off and hand it over to someone as well. So please, I would, you know, suggest strongly, if you've not had to look at that, have a little look, because it may actually give you some suggestions that you've not thought about, or not thought about what you want to discuss perhaps at your next clinic appointment or your next general hospital appointment, just to let them know what's going on. Helps you to get your views and opinions across. Just to say at this point as well, some really good questions that I can see are coming up from you all. So if we're not covering them at the moment, we are going to hopefully be going back to most of them. And next slide there, please.
Okay, so I'm aware that time is moving on. I think we should move swiftly through this slide. And just to say again, Many of you will never experience any complications, but this is just so that you know what could happen so that you can get help with it. We've talked a bit about tiredness and anemia, and I'm just going to mention a few things that you may not be aware of. Sometimes you can get sore, painful eyes, and that's called iritis. We've talked already about mouth ulcers. Crohn's particularly can lead to narrowing of the bowel, and that can cause pain on eating and even a blockage. And then two other things, your joints can be inflamed, and that's a bit like rheumatoid arthritis, but different. And so joint swelling and pain can occur in association with IBD. And skin rashes, surprisingly common to have problems with your skin. And if anything like that happens, ask advice because it could be relevant. Okay, next slide.
Okay, so I'm just going to really quickly run through this so we've got some time for questions. How often you're followed up really will it depend greatly on the extent and the severity of your disease. The majority of patients with IBD will be followed up long term, either via clinic visits or phone calls. But when your disease is stable, you're unlikely to be seen as often. And the idea being when your disease is active, we can see you quite quickly. Increasingly, as we move on, patient apps, flare cards may be used to give patients a little bit more control of their own disease. And somebody's asked in the pre-questions, how and when do we reduce medication? And I hope that we've talked already about when you're in remission. And by that, we mean both your symptoms being better and your endoscopic or your blood and stool samples being better. Then we can talk about perhaps bringing your medication down. But we've tried to emphasize that particularly for ulcerative colitis, you will need long-term medication. I think we've said enough already about blood monitoring. So can we go to the next slide? I think it's just important I mention that surveillance colonoscopy is needed for all but patients with just disease limited to their rectum. So the majority of IBD patients will need what we call a surveillance colonoscopy, which is a camera done about 8 to 10 years after diagnosis. And then how often you have it thereafter will depend on what's found. The idea of this being is that we're looking for very early changes in the bowel wall that suggest that there may be a risk of progression to cancer before that cancer develops. And we can do this in a couple of different ways, either by taking biopsies or by using a dye spray. Having the regular colonoscopic examinations also means that if you do develop a cancer secondary to your disease, when you've had it for a long time, hopefully we pick that up at a very early stage and treatment could be offered. Next slide.
So you've heard me talk about Crohn's and colitis quite a bit, and this is another QR code to take you to the link there. There's also Gets UK, and the general NHS website is also giving you some good information, but probably gold standard certainly for adults, the Crohn's and Colitis UK. There's also CICRA for children. I believe there's a few people on here with some children and young people. CICRA, it's CICRA, and that's for Better Lives for Children with Crohn's and Colitis. My last little gem of wisdom to you all is just please be aware of what you're reading. Just because it is online does not necessarily mean it's accurate, and there is certainly some distinct untruths there. So I think we're hopefully going to move on to some questions now.
Thank you so much, everybody for that wonderful talk. It's been really, really great. And there's been lots of questions coming in whilst you've been going, which has been lovely to see. So thank you everyone for sending in your questions. You can keep sending them in whilst we're doing a question and answer now. So if any more crop up as we go, then do send them in. I think if we start with, there's been a lot of questions about diet. So, and we've Helen's talked quite a lot about diet, but we could maybe go into a few more of those first, if that's okay with everybody. So people are asking, about supplements that they could take, probiotics, as Helen touched on. We've got somebody here who said that their daughter was recently diagnosed with ulcerative colitis, and she's a vegan. So is there any particular advice about those sorts of diets? So perhaps Barney might like to touch a little bit on that for us.
Yes, thank you very much. Yeah, I mean, this is always a really popular question area because we're not very good at telling patients about diet. And one of the problems is that we think that diet must be really important because of the impact it has on the bugs in your gut, which are part of this. But the problem is that we don't understand how those bugs work. And also, everybody is different. So lots and lots of the things that you read on the internet, we've talked about Chinese medicines, there are all sorts of other strange things. They may work for some people, but they don't always work for everybody. And it's really, really important to realize that you're an individual, and what you try, if it works for you, that's great. So there are some specific things that we can say in terms of what should you eat. For instance, if you're newly diagnosed with ulcerative colitis or Crohn's disease, we do emphasize the importance of a healthy diet. And that means lots of fruit and veg, lots of nuts and seeds and roughage, fiber in your diet, and also avoiding very fatty foods, avoiding high salt foods, and avoiding foods with lots of sugar in. Processed foods have things called emulsifiers in them often, and there's a little bit of evidence in the laboratory that emulsifiers may not be a good thing. So too much very processed food may not be so good for you. I think we ought to say a little bit about probiotics. And the interesting thing here is there's good evidence, some growing evidence in ulcerative colitis that there is a benefit in helping you to get into remission. But all the studies that have been done have been alongside conventional treatment, drug treatment. So there is a little bit of evidence that it helps you if you've got active disease, helps to calm it down, but it really only works in mild colitis. The severe colitis, it probably won't work. And once you're in remission, under control, there is no real good evidence that continuing those probiotics long-term is helpful, okay? In Crohn's disease, the evidence is not as good about probiotics. But I always say to people, it is really healthy to have fermented food in your diet. Things like live yogurt, sauerkraut, sourdough bread, those sort of things are good for your general health. Although I would say they make me a bit windy, but that's just one of those things. Nothing wrong with wind. So there are probably some other questions people have loads of questions about diet, but that's just a sort of a brief introduction. Emily.
Thank you, Varney. So yeah, a few more questions is coming in. Somebody's asked here about the control of IBD and whether there's any evidence of the condition getting worse over time, or do you, if you are diagnosed with a mild Crohn's or colitis, is it likely to get worse at times, or will they stay at the level that they were when they were diagnosed? I suppose that would be best for any of you, really, if you've all got expertise in that. Maybe Helen, what do you think?
I mean, there's certain criteria we know that where we suspect people are going to perhaps have a bit more of an aggressive time of disease. So sometimes that can be onset in young age, perhaps admitted to hospital at first presentation. Certainly someone who smokes, we would anticipate that, with Crohn's disease, if they keep that going, they're pretty sure going to have a more turbulent time. I mean, I have looked after patients that, I've known myself for 18 plus years, and they have good and bad times, and it's not as clear cut as you might think, but yeah, you can have really severe disease and then go into remission for quite some time. Equally, you can be really good for years and years and years and certainly have quite a difficult time. Barney? And
perhaps Helen, I could say that it's really important to emphasize that a lot of people with mild disease never get bad disease, and it's often the way it behaves at the beginning, which is that often it's the worst. So quite often people who present very suddenly with very bad disease may have a rough time, but quite often it's come on very, very gradually. They have mild disease and it won't necessarily get worse. So it's really important to realise that.
Lovely. Thank you. So we've got a few questions about screening and surveillance. Keris, you sort of were talking a bit about screening towards the end of the talk there. Somebody's asked, they've said, with today's obesity crisis in the general public, is there a propensity for overweight people to have inflammatory bowel disease in a higher proportion than those with a normal BMI? And is
so
there
perhaps
a
I could come in very quickly there and say the answer to that is no. We don't think you're not more likely to get IBD if you're overweight, unless you're overweight because of your diet, because there may be dietary factors, as I alluded to earlier. But the funny thing about being overweight is sometimes you don't respond quite so well to your drug treatment if you're very overweight. So that's very important. Okay. Emily.
Thank you. Keris, as well, there's another question about colonoscopies, and again, you know, everybody can jump in on this one. Somebody said, as the gut bacteria influence the severity of inflammatory bowel disease, has it ever been noticed if there's a flare-up or improvement following the prep for a colonoscopy in the way it flushes out the colon?
I think prep for colonoscopy can go one of two ways. I think you certainly have people that have proctitis or lower disease that can actually have a proximal constipation. So beyond that inflammation, they can be constipated, and actually that can only perhaps become apparent, or they can only perhaps appreciate that once they've had the prep that's given them a good clear out. And there are other people that I think, you know, once they've had their colonoscopy, they can feel more unsettled for a time after it. But I think, you know, I don't think it's fair to say that a colonoscopy induces a flare or that the prep heals it, unfortunately.
Yeah.
It's an interesting idea, isn't it? You don't have to be a film star to have colonic irrigation. just come to the gastroenterology clinic. But I think some people with irritable bowel sometimes are better if their bowel is emptied out, and it's tempting to think that's because we've changed the pattern of bugs in the gut. So it is plausible, but the evidence isn't very good, and we don't recommend it as a treatment.
I think you mentioned, Emily, about screening, and I think there was a question that had come up earlier, and I didn't mention in tests about fit testing, and someone had put a question in beforehand about bowel screening Wales, and do we test, you know, do we screen? And I think the question was, do we screen for IBD? And the answer is we don't screen for IBD, but if you reach the age of being screened for bowel cancer and you were to have a positive result, all that tells you is that you need further investigation, and that investigation might show that you've got Crohn's or colitis. And I've got patients that we've picked up because of a positive bowel screening Wales test. So the FIT test is a test that's often used, again, it's a poo sample, and it's often used because of a change in bowel habit in an older population rather than the calprotectin in the younger ones, or it's used as part of the national screening program for bowel screening, but it's measuring blood in your stool rather than inflammation. So again, it's not specific to what the underlying problem is. So it doesn't necessarily mean a positive result, doesn't necessarily mean that you've got a bowel cancer. It just means that you need to go on to have further investigations.
Yeah. And could I add a little bit about families where there is IBD? And the question was asked, you know, should my children be screened because I've got IBD or my husband has got IBD? And the answer is we don't recommend screening, but it's just important to realize that there is a slight increase in risk. If one parent has got IBD, then the risk is between 2 and 10-fold increased for the child, but it's still not that common. Of course, if both parents have got it, the risk is greater. And remember that the genetic component is slightly more for Crohn's than for UC. And then there's some other really interesting things. Mothers are more likely than fathers to pass it on to their children. And if their children is a daughter, slightly more likely to get it. But we're only talking about slight increases there. Okay.
Thanks for that, Barney. There's a really interesting question, I think, sent in earlier. And I don't know, maybe Helen maybe knows, probably been asked about this in clinic a lot. The question was, has there been an increase in inflammatory bowel disease since COVID? We've got a lady who's wondering whether her child's COVID may have sparked them developing UC. And also somebody's asked about the same about the COVID jabs as well.
Okay, so I mean, don't quote me on this, I would say. So I'm talking about perhaps our experiences. I must say we feel that we have noticed that since COVID, we've perhaps had a lot more calls. I mean, we know that the rate of diagnosis of IBD is going up anyway. So whether that is related with COVID, I don't know. There were bowel side effects of COVID reported, of diarrhea, and certainly I am hearing from a lot of patients that they feel that it has unsettled things a lot. Again, whether that is to do with the gut microbe, I don't know. Perhaps we're finding that people who have been stable a long time are getting more symptoms, but it's really difficult to tell. I dare say within a year or two there will be more data on this. It also could be actually just that your IB team are a bit more exhausted than usual after the last few years, so maybe we're all just feeling it. Barney, have you heard anything?
No, well, I think the short answer is no. I don't think there is any good evidence, but remember that an infection, a gut infection, can trigger or start off colitis. That is well recognized. Sometimes people get it after they've had salmonella or clostridium or something. I think the evidence for COVID is much less. And I don't know of any evidence that vaccination makes you more likely to get it. Okay. What we have noticed, though, is that during the pandemic, because people couldn't get to see their doctor, they presented later and with worse disease. That's been very striking and very sad.
Yeah.
Yeah. Okay. There's obviously been lots of questions about the treatment of Crohn's and colitis, so we've got quite a few areas to speak about of that. Somebody's asked about treatment for pediatric UC specifically. I'm not sure whether that's too personalised or if there's a general sort of answer to whether there's other options for pediatric for children with UC.
So perhaps I could jump in there. So the question was for somebody who's got a child who's got UC and who's had infliximab and vedolizumab, which are two of the biologics, and they don't work. What are the other options? Now, it is a problem for children because many of the trials for these new drugs have not been done in children. And the answer is there are other drugs, but there isn't just a good, strong trial base in children, but most of them are okay in children. And you need to talk to your consultant or your IBD team because there are more drugs that we use in adults, and they can be used in children who really, really need another option. Okay.
Okay. Thanks, Barney. Another medication question. Somebody's asked, during flare-ups, what happens if steroids don't calm things down?
So again, I could jump in there again. Some patients develop steroid resistance, which means that their steroids used to work really well, and then suddenly they don't work anymore. And the short answer is that you need to move on swiftly. If they're really not working, you need to talk with your team about going on to other alternatives, because as you can see, there's a growing list of other drugs we can use.
Yeah.
Can I just add there that again, that probably comes back to just checking it is a flare and making sure that other causes, because sometimes it's because there's an infection that hasn't been excluded and steroids may make it worse rather than better. So it just comes back to that confirming it's a flare.
Yeah,
that's a very good point.
Okay. And I mean, I suppose that then leads on. We've obviously had a lot of people thinking about the prospect possibly of surgery at some point. So we've had a few surgery-related questions. Somebody's asked whether surgery is really the only option left once biologics have all been tried and exhausted. What do you think?
That's a really difficult question, isn't it? I mean, there are a lot of drugs. There are some people who have been through 4, 5 or 6 different treatments. And I think the important thing is to remember that surgery it's not the end of the world. It is not what to do when everything fails. I always try and get my patients to look at surgery as an option amongst all the other drugs. And one of the other questions was about fatigue and what happens after surgery. How quickly does that fatigue get better? And all I can say is that some of my patients who come to have surgery after several drugs, they say, gosh, I wish I'd had that operation earlier because I feel so much better. Because it is a burden being both ill and having these drugs, and you continue to feel ill because they're not working. But very often, if you have the right operation, you feel better within weeks, actually. It's quite striking.
Yeah, I'd like to sort of second that if I can, actually. I mean, we get the majority of patients with ulcerative colitis that go on to have surgery literally do say, I wish I'd had this done ages ago. And I did actually have one chap was big into football. I mean, he was back playing football 6 weeks after. And bear in mind, majority of surgery these days is done with keyhole surgery, again, which again speeds things up. But I think, yes, I saw that question about tiredness after surgery. It's still major operation, and you've also got to think, is there a psychological element there? Particularly if you've got a stoma, your body perception, the way you feel about yourself, the way you may think you look has changed, and that is going to have an impact on you, as positive as you are. So again, I would be kind to yourself and tell someone if you're struggling.
Yeah, absolutely. Well, I second all of that. I'm sure you both must have heard me say after my surgery, I had a colectomy when I was 21. I wish I'd done it sooner, and it was absolutely life-changing, and it was wonderful. And the fatigue levels, I mean, lots of our audience are probably getting up multiple times through the night and haven't slept for months, years maybe, and you start sleeping through the night again, and it's absolutely fantastic. So just aware of the time, I think we've got about 10 minutes left for questions. And one other question on surgery, somebody asking whether everyone who has a colostomy for UC is able to have a reversal.
Yeah,
Barney?
okay, so perhaps I could go for that one. First of all, it's not a colostomy. A colostomy is where the colon comes out to the skin. After a colitis surgery, you have an ileostomy because it's the ileum that comes to the skin. The answer is that you can have a pouch. What you need to have a good pouch operation is you need to have a strong bottom muscle, the anal sphincter. If you've got a very weak muscle, and this can be a problem in the elderly or people older, or if you've had loads of children, if you're a mother, that muscle can get a bit weak, and that means that the outcomes can be not as good. More chance that you're going to get leakage. If you haven't got a rectum, what comes out of your pouch will be loose, always. Okay, it's never going to be absolutely solid. And most people with a pouch will go between 4 and 7 times each day. Now that sounds a lot, certainly not normal, but of course, if you feel much better, it's not a problem. Some people can develop inflammation in the pouch, and then it's a bit like having your colitis back again. So pouches are not perfect. The majority of people can have a pouch. It means a lot more surgery, and some people decide that actually having an ileostomy is not so bad, and they stick with the ileostomy, which is the safe option. Okay.
And just to add there, I mean, there certainly are categories of people where the completion surgery is not in their best interest, perhaps for significant obesity. Sometimes please bear in mind that the pouch formation is actually more complex surgery than just the original getting rid of the nasty colon bit and bringing out the ileostomy, because it's deeper in the pelvis. So there can be cases as well, if a lady is wanting to have children, sometimes it's advisable to actually not have completion surgery until after they've had their family. Also the general health of the person. So again, I've come across cases where actually the person themselves is in really poor health, and the anaesthetist and the surgeon perhaps is not that keen on going back in. So for the majority of people, yes, it is possible, but there are certain people for whom it's probably a really bad idea to do any more surgery.
Yeah. I think I would also add that, you know, with each of these operations, people are having, you can get scarring obviously on the inside, and that can add further complications later on. There's sticking with sort of treatment. There's another question here about pain control during episodes. So not talking about sort of medication to reduce the inflammation, but how is there anything that people can do to manage just the pain specifically? Because we already know that some of the medications actually some of painkillers make Crohn's and colitis worse. Keris?
Well, I think this perhaps comes back to some of the other issues that we've talked about in your general well-being. So particularly, you know, we know that you're going to need to avoid non-steroidal anti-inflammatories. Again, codeine is constipating, so we've, you know, wherever possible, try and manage it in a non-pharmacological way without tablets. And things like exercise, again, can be very good at helping patients control pain. And this might not be active sort of cardiovascular exercise, but things like Pilates. So again, you know, it's looking at perhaps alternative ways to address it. Again, I think it perhaps comes back a little to your mental health as well, because we know for sure that if your mental health is struggling, you're going to struggle a lot more to manage pain. So again, looking at whether perhaps this is an undiagnosed low mood, depression, anxiety, and discussing this, and maybe looking at some therapies such as just meditation, using things like the Calm app. So for non-medical options, and again, of course, diet I'm not going to go into, but I think that this again can play a key role in managing some of the symptoms related to pain, because of course we've talked about IBD and IBS being different diseases, but that doesn't mean to say there aren't overlaps. So that having pain doesn't necessarily mean this is a flare or it's my condition being poorly controlled. That patient may well be suffering from pain from IBS, and the management of that, I would say, as much as possible, needs to be non-pharmacological and addressing the things I've just mentioned.
Yeah, that's a really important point, Keris. I'm glad you brought that up, because it's complicated for patients to understand that you can have IBD, which is perhaps under control, but loads of symptoms because you've got IBS as well. And that's where fecal calprotectin can be really useful. If you've got loads of symptoms, but your fecal calprotectin is normal, then you need to talk to your doctor and say, have I got IBS as well? And then it's more useful to look about your diet, things like that, to try and treat it.
And I can see there's a question that came in asking, can a change in bowel habit and constipation indicate a flare? And I think that we often talk about diarrhea being a flare. And again, I think this is, yes, you can get constipated with a flare. That doesn't mean you're not having a flare, but there is, you know, it comes back to maybe needing to address that this could be IBS.
Yes, and also to emphasize that Crohn's disease, if it's suspecting the bottom end of your small bowel, often you don't get diarrhea at all with that. You just get pain and lose weight. But colitis, nearly ulcerative colitis and Crohn's colitis, nearly always there is diarrhea with a flare.
I think that's really helpful. Some really helpful answers there. We've got about 5 minutes left, and I think it would be good just to touch on pregnancy, because we have done a little bit, but there've been a couple of questions coming in. Just people wondering whether the use of steroids is going to be a problem, or whether they're.
Yeah. So perhaps I could just say very quick words about pregnancy. The most important thing about pregnancy is most drugs are safe, and that includes prednisolone, steroids, except in the very, very early stages of a pregnancy. And there is only one drug that we get nervous about, and that's methotrexate, but we don't use it that much anyway. Most of the other drugs are safe, and the important thing is to take advice from your team as early as possible. I've seen lots and lots of patients who've had a really bad flare because they stopped their azathioprine at the beginning of pregnancy because they were worried about the baby. And there is no reason to stop it. It is as safe as any drug can be, and that includes for breastfeeding as well. And we're learning that most of these biologics are safe as well, but you need to take advice from your team. And sometimes one of the other questions was about what happens to how active my disease is during the pregnancy. The best guide to what's going to happen is how active you are when you get pregnant. If you're in remission when you get pregnant, you're more likely to stay under control. And if you've got active disease, you're more likely to continue having trouble, which is kind of common sense. So the key thing is to try and get your disease really well controlled before you get pregnant, but then to stay on the drugs as long as you're told that it's safe. And then there was another question, I think, about what happens if you have after you've had the baby. Is everybody going to have a flare or something like that? The evidence is for Crohn's, it's not, there isn't an increase in risk, but there maybe is a slight increase in risk of flare in ulcerative colitis after the baby's born. That doesn't happen to everybody though, but perhaps the risk is slightly increased. And you need to bear that in mind and jump on it early with extra treatment if needed.
Okay, thank you. So we've only got 2 minutes left, but there are some questions about whether there's any apps that could help people monitor their flares. Maybe Helen might just want to say a couple of words about some apps.
Yeah, so I mean, certainly some hospitals, particularly some of my colleagues in England, they have apps that are also linked with their patients' medical notes. That they can actually talk back and forth between yourself and the hospital. I'm pretty sure that will be the case in Wales in probably the not too distant future. There are some good apps. Depends what you use them for. Yes, you want to be very aware of your symptoms, but I would really advise, if at all possible, don't record every bowel motion. Don't become obsessed with this. That's really important. You also need to live your life, but absolutely, it can be helpful for a little while to note any changes, and that there are various apps available, none that we particularly would recommend at this point, but again, hopefully in the next year or so that will change.
Lovely, thank you everyone. Okay, so I think we're going to need to wrap it up there now. Unfortunately, thanks to so much to Barney, Keris and Helen. That's been really, really wonderful. I wish I'd have done something like this when I was first diagnosed. Thank you to everyone for sending your messages in. In the question and answer bit where you've been sending your messages in, there's going to be an evaluation questionnaire. We really want to do more of these sorts of talks, so it would be extremely helpful if you could answer that this evening if possible. Put as much information in there, and any other topics that you wish we'd have covered, that we would find that quite helpful then if we were able to ever do this again. And yeah, I just hope it's been worthwhile, and that everybody's got something out of it, and it's given you the knowledge to understand your disease and the illness, and hopefully talk to other people about it, because you talking to someone else may well help them with their journey and encourage them to talk about it as well. So I don't know if any of the other speakers want to say anything, or we'll call it an evening at that.
No, just thank you for sharing it, Emily, and thanks to everybody who's helped to make it happen.
Yes, a big thank you to everyone. Thanks everybody then.